I've been teaching this class so long that now everyone looks like somebody. You all look like a former student, and it's really confusing me. So I'm thinking, I give them random names because it doesn't matter anymore. It looks like somebody else. So also, they keep giving me new TAs for this class. Apparently we have a new one coming, which is good, which means I never have to talk to any of you, which is fantastic. So I'm joking mostly. All right, so today's topic, we're going to look at measurements, two things, measurements of morbidity, general mortality, and then measurements of mortality again. And for some, if not most of you, this hopefully will be something resembling a review, because I think you must have covered some of this in stats or research methods. And if not, it's at a very basic level, so you'll be fine. I'm going to try to pin this to my lapel, see if that still works. Sometimes it doesn't work. Yeah. It's not working. Does that work? Yeah? Am I still mic'd? Good. All right. This, by the way, is a Donald Trump shirt. I'm wearing a Donald Trump brand shirt because I got it on sale at Winners like 10 years ago. It was like $1.50. So that's what it's worth. It's pretty stylish, though. I kind of like it. So I'm looking extra douchey today. That's why. Got that Trump spoor on me. All right. So we're going to talk today about risk. What does a risk mean? So much of what population epidemiology is about is measuring and quantifying risk. And we like to think about, what's the risk of, traveling to Europe and being present during a terrorist attack. There's a conversation I had with someone recently who was afraid to go to Europe, and my response was, well, the risk is actually vanishingly small. You shouldn't be worried about that. The higher risk is renting a car there and driving to the airport where probably you're going to forget what side you're driving on and kill yourself. So how we quantify and consider risk is an important part of this process. I had a paper many years ago with an undergrad co-author who looks a lot like you. It's creepy, huh? So, yeah, she looks a lot like you, which is freaking me out. And this was like many years ago, and we looked at risk perception for Americans right after 9/11. And the question was, were they also freaked out by 9/11 that they decided to drive instead of fly? And if they drove more, did they die more in car crashes? And the answer was yes. The answer was yes. We had data looking at, flights taken, highway traffic congestion and highway traffic accidents, and sure enough, in the period immediately after 9/11 compared to the period before 9/11, the rates were up. So that was a quick and dirty publication that went nowhere, but it's fun. So here's some examples of risk. Smoking more than one pack of cigarettes a day increases the risk of cardiovascular disease, blah, 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 blah. Okay, that's one quantification. Normal rate of miscarriage of pregnancy is 2 to 3%, and amniocentesis increases that risk by an additional 0.5 to 1%. Why is this important? This kind of information allows patients to make, informed decisions about their own care. It allows clinicians to advise their patients about appropriate care. It allows policymakers to decide which kinds of interventions they're going to support in their jurisdictions and so forth. And by the way, I'm not going to ask you to cite these statistics, so don't worry about it. This is for flavor. Here's another one. 1 month delay in treatment of an early stage primary breast cancer increases the risk of axillary lymph node involvement by 0.9%. So the questions we ask them, is that a lot? Is that significant? And at some point down the line, we'll have that conversation about what is significance. We touched upon it earlier. Is significance statistical significance, or is it clinical significance, or is it emotional significance? That varies greatly. Is that background noise? Is that me, or is that something else? It's me? All right, let me see if I can reduce that. Is it gone? It's not me. All right, fine. Okay, so what is risk? Risk is the measurement of the occurrence of new things, of new cases of a disease, for example. We know that has another name, incidence. We'll talk about incidence a lot today. Or it's also the probability of attaining an outcome given that something has changed, given that intervention has changed or risk factor has changed or something of that nature. So it's technically the measure of new cases, as I said, which is a measurement of incidence. And as you know from your research methods class, incidence is different from prevalence. What's the difference, members? Yes? That's right, new cases versus existing cases. Now, for those people in my international health class, there's going to be a lot of overlap today between what we did on Tuesday, but that's to be expected because I'm the same guy teaching. So here is how we perceive incidence. It's new cases divided by people at risk. Who's at risk? The people who don't yet have the cases and who can get them. Now, this is different from prevalence, as you will see, because prevalence, the denominator, is everybody, including people who already have it. So a tricky way of thinking about it is things like who's at risk of getting pregnant? Fertile women, right? Or you can say women who are trying to get pregnant. So it depends a lot on the conceptualization as well. Is it wrong to measure the incidence of pregnancy in a population using a denominator that includes men? Probably, but you can make an argument for it if you're comparing populations as a whole. So this isn't a hard and fast rule. It depends on the story you're trying to tell. But for the purpose of this class, I won't trick you like that. Just keep in mind that it's the people who are at risk. I will trick you to the extent that if you've already got measles and we're looking for the incidence of measles, well, you don't include the measles people in the denominator. Okay? So this is a ratio. Risk is a ratio. Every time we have a ratio, we're dividing units by themselves. When you divide units by themselves, you end up with no new units. So this is a unitless measurements. It's important mathematically because we can divide through units and other things like speed, meters per second. That's units divided by other units. And that's important for how we're going to convert later on. But with ratios, the units fall away. We can also express as a percentage, which is preferred. Here we go. If one person in a group of 6 gets flu, the risk of getting flu in that group is 1 over 6. So 6 were at risk, and so forth, 17%. Okay. In 1,022 cancer patients, 530 develop bacterial infections. What's the risk of infection in these patients? Well, 530 over that number, right? Straightforward stuff. Grade 3 math. Pretty cool. So before we get into the nitty-gritty, let's distinguish between mortality and morbidity. Mortality has to do with death. So it's the rate of death. In the case of epidemiology, the rate of death due to something that is disease-oriented, usually. But we can be talking about rate of death due to car accidents, rate of death due to warfare. That's also valid epidemiological investigations. But in general, we'll be specific around some kind of health thing. And morbidity is either prevalence or incidence, or measurements associated prevalence incidence. It's the rate of a presence of a disease in a population, or a disease state of some kind. Now, prevalence, we'll talk about today. We're going to look at two aspects of prevalence, point prevalence and period prevalence. And incidence, the two important distinctors are, is that a word, distinctors? No? Sounds like sphincter, distinctor, sphincter. All right. There's a joke there somewhere. I'll come to me later, I guess. So cumulative and incidence density and how we compute them is significantly different. So it's important to get that straight today. Right? So incidence, rate of new cases, prevalence, rate of all cases. I'm using the word rate incorrectly for the most part here. A rate technically has a denominator that includes a measurement of time. So velocity is a rate, meters per second, that sort of thing. Incidence sort of does have a rate in that it's going to be new cases in this population in a period of time. Prevalence in general tends not to be a real rate. So forgive me if I use the word rate incorrectly, and be aware that other epidemiological sticklers would disagree with me, but I don't really care. Use the word rate fluidly if you like. So, incidence, the number of new cases that occur during a specified period of time in a population at risk of developing the disease. We can constrain that population to risk to look at sex, occupation, whatever demographic criteria we care about. The denominator is the population at risk, as I mentioned, and not the population as a whole. Time must be specified, hence this being an actual rate, because time is going to be in the denominator. And time is arbitrary. So it could be a week, a month, a few seconds, whatever matters to you. In general, though, we tend to look at a year, right, for population epidemiology, and maybe weeks for clinical epidemiology. We can express it as a percent or as a rate per 1,000. If that confuses you, that's basic arithmetic. So it has confused some students in the past. I encourage you to be able to convert back and forth between percentage and rates per 1,000 or 10,000 at ease. Or, as we're going to see today, expressed as person time. And that's going to be a little confusing, but that is only for the cases of computing incidence density, as we shall see. Anytime you see a denominator that's person time, meaning women years, man hours, person weeks, whatever it might be, that's a measurement of incidence density, as we will see. Okay, in general, this is how we express the formula for incidence. Number of new cases over population at risk, A over P, over a specific time period, hence the rate. Sometimes we follow a single population to see how many new cases erupt over the course of a year, for example. Right? And that's pretty straightforward. Let's say I've got a population of Ottawa, 1 million people, and in the year 2016, I look at how many new cases of measles there were. Pretty straightforward. Or, more complicatedly, we follow a series of individuals at different times. And this is very common in clinical studies because if I'm enrolling people in a study of, pregnancy, right, pregnancy outcomes, not everyone in my study is going to get pregnant at the same time. I'll have to recruit them throughout the year, and I'm going to follow them at different time periods. So they'll be at risk for different time periods. And this is where we get into the density argument, and we'll see that in a second. So we're measuring here cumulative incidence and incidence density, two separate, distinct concepts. Both are looking at new cases arising in the population, but somewhat differently. This one is new cases in a population we're watching, and this one is new cases amongst individuals probably being observed for different periods of time. This one usually we do in population epidemiology, and this one usually we do in clinical epidemiology. The math for this is easy. The math for this is a bit more challenging, as we will see. So, cumulative incidence we also call incidence proportion. We meaning people I've never heard of. I've never heard it called that, but the textbook claims it, so I'll say it. And it's, again, the incidence computed over a period of time during which the entire population is considered to be at risk. So we like it for a city, for example, or a school. Like, hey, there's a HPV outbreak in Ottawa U this year, so you're all at risk for the year that you're here, right? That kind of thing. And the density includes in the denominator the sum of the time in which the people were at risk. This is where we get into the person years thing. Okay, so again, individuals are being followed for different amounts of time in the second case. So let's do incidence density first, because it's the hard one. Here's the formula. A over PT, where P and A are the same as before, but T is the duration of risk. And the critical expression here is that this is given as a rate per population time, woman hours, man weeks, whatever it might be. And I encourage you to be adept at converting back and forth between various measurements of population time. It's simple arithmetic. Just got to get it straight in your head. Okay, here's an example of cumulative incidence first, okay? This is 60 people attending a one-year-long residential detox program in Edmonton. 50 tested HIV negative at the start. At the end of the program, 3 of those 50 tested positive for HIV. Now, this is not an unusual way for me to phrase a test question, because I'm throwing a lot of numbers at you. You've got to extract the right numbers to divide. Everything that we do in this class really comes down to dividing 2 numbers. Grade 3 arithmetic, right? So because it's so simple, I got to confuse you somehow by asking questions with a lot of information. The intellectual challenge here is extracting the right information. So let's start again. 60 people attending 12-month residential detox program. Look, 2 numbers already. Confused? 50 tested HIV negative. Oh, 3rd number. At the start of the program. At the end of the program, 3 tested positive for HIV. Oh, another number. Okay. So what is the cumulative incidence of HIV? That's pretty straightforward. So we have 3 people out of 50. Who got it? Where's my answer? Yeah, 3 out of 50, 6%. It's very straightforward. That one's easy. But incidence density, on the other hand, will look like this. We have 1, 2, 3, 4, 5 people, and this is a typical graphical depiction of how we show the length of time people in a small study have been observed. As I mentioned, they may not arrive in your study at the same time. If it's pregnancy, for example, women show up at different times of the year because they get pregnant at different times of the year. Here we've got people at a residential program who are showing up at different times and signing up, so we can't tell when throughout the year they're going to show up. As a note, in a future class, we're going to do something called right censoring. So I'm going to tease you with that term right now. Right censoring means we pretend they all start at the same time. We'll do that later when we do complicated survival analysis. But here, don't worry about it. So here, subject A starts in January 95, and they continue on until January 98, at which point we stop following them, or they leave, or something. Right? We call that being lost to follow-up. If somehow we're no longer following up the patients, they've been lost to follow-up. We don't know what their outcome was. Subject B started in July 96 and continued on, and then here in 99, they got the disease we care about. In this case, I think it's HIV. Subject C started here, and they went out through the entire study and never got the disease. Subject D started 97 and lasted the entire study and never got the disease. And subject E started 98 and got the disease 2 years later. Okay? So it's important to look at the legend here. So how do we compute the incidence density for this case? We have to take in consideration there are 2 people who got the disease. That's our numerator. There are 1, 2, 3, 4, 5 people in the study as a whole. It's not 2 out of 5 because they weren't all being exposed at the same time period. So we have to consider that this guy was watched less time than that guy. So the way we do it is we incorporate this measurement of person time. So let's do that. First, I'll show you the answer. As I mentioned, if we're computing cumulative incidence, it would be 2 cases over 5 people over a 5-year period. So that's 0.4 over a 5-year period, or convert that to 1 year, we get this. We can convert it to 8 per 100. You see the different ways of expressing the same number? Simple grade 3 mathematics, but become adept at that because there are some asshole professors who would ask you to convert them. And I know one happens to be in this room, and he's handsome as hell. Okay. This is a misleading measurement because, as I mentioned, these individuals weren't followed for the same amount of time. So if we're computing it from a density perspective, which is what we should do, here we've got the total time in which all these people were observed. This guy observed for 3 years. This one for 3 years as well. This one for, 6 years, and so forth. We add all that up, we get a total of 16.5 years. So 5 people observed 16.5 person years. That's 2 cases over 16.5 person years. And divide that out, we get 12.1 over 100 person years. And that's the measurement of incidence density. If it's not clear, we're going to do another example. How do we get that? Again, total time at risk. First person at risk for 1 year, second person 3 years, and so forth. Add it all up, and we get these numbers. So, ReWalkville has 1,000 people. Over a 2-year period, 28 people developed dumbass disease. What's the incidence of dumbass disease? By the way, I've been using this example for 9 years. Every year somebody complains about the inappropriateness of dumbass disease, and that person is a dumbass. So, wow, what's I mean, you want a real disease? Want to make you happy? It's ridiculous. Okay. So, incidence, this is an interesting example because these 1,000 people are actually being watched all at the same time. So it should be a cumulative incidence example, but I bring it up to show you that you could use a density approach on the population scenario as well. So here we have 28 cases that were popped up, over 1,000 people in ReWalkville. They were watched for 2 years. So just divide through and get 14 cases per person year in that very simple example. This one, 5,000, and this was taken from a textbook, by the way, 5,031 patients were observed for a total of 127,859 patient days. Okay. And this number of patients developed a nosocomial infection. What is the incident rate of nosocomial infection in the hospital? Give it as a number of cases per 1,000 patient days. This is not an atypical way in which I would phrase a question. I would tell you how to give me the example. And this is a bit of a trick question because I've already given you the denominator. That's the denominator, 127,859 patient days. But here we got 1, 2, 3, 4 numbers, and you got to choose which ones to divide. Which one is it? Well, these patients were the ones who got the disease out of this many patient days. Okay, there it is. So 596 new cases divided by this many patient days, and we multiply out to get per 1,000 patient days. If you don't believe me, try it yourself at home, and it'll work out for you. Another example. Okay, so in the USA, the National Cancer Institute maintains a network of registries. a surveillance network, if you will, and we'll talk about surveillance. You probably noticed that this slide deck is enormous, right? Every year that freaks people out. Don't worry about it. The last 75% are just examples. I don't need you to know. It's just fun stuff. Okay. Every year someone freaks out. Oh, guys are going to know. Yes. No. Relax. Okay. So all these surveillance registries cover about 14% of the population, and between these years, this number of women were diagnosed with this kind of cancer. Again, all these numbers being thrown at you. Where am I going with this? So this number of women lived in these combined areas on average during this 5-year period. What's the total number of woman years for this period? Okay, that's the first question. And second, what's the incidence rate for leukemia in this period of population? So total of woman years. That's going to be the number of people being observed for a certain period of time. So we have the numbers here. There we go. So this number of women in these areas being observed for 5 years. It's simple. It's 95,000 blah, blah women years. Incident rate is how many got the disease? Well, these people, this is a numerator over here. So divide it through. You got 0.03 cases per 1,000 women years. So half of the trick is reading the question. Right. This is a more easily understood example. Here we have a clinical population of 1, 2, 3, 4, 5, 6 people, and they were observed for 8 years, 0 to 8 years. And during that time, 2 got dumbass disease. Which 2? These 2 here. Okay. This first one got dumbass disease, stuck around in the program, and died of it, died of acute dumbassedness at 7 years. Right? This guy got bored of us and left after 2 years. This guy got dumbass disease at 3 years, stuck around and realized we're no help to him and left at 5 years. And this guy lasted the entire clinic. I guess he's being paid and just left, and so forth. Right? See what happens here. It's important to look at the outcomes and what we're asking. Here we're going to ask about the computing the incidence rate for dumbass disease, not of death, of dumbass disease. So, how long was this first person observed before getting dumbass disease? 2 years. How long was this person observed before getting dumbass disease? 2 years. This person, 3 years. This person, 5 years. They never got it. So that's the total of how long they were observed for. So we're going to look at, we're computing here incidence density, obviously. So patient A, 2 years. B, 2 years, and so forth. So this is how long they were at risk of getting the disease. Remember, you're not at risk of getting the disease if you've already got the disease. So he stops being at risk once he gets it. So my incidence rate becomes the 2 that got it, 2 divided by the total number of years they were at risk. So 2 out of 22, or 9 cases per 100 person years. That is the incidence density for dumbass disease in this population. Right. You could do incidence density for large populations, as we've seen. If you're doing something for, like, Ottawa, the problem there is that people come and go. We don't know exactly how many people are here at any given time. Let's say we're looking at measles, right? We're doing the incidence density for measles. I don't know why we would do that for a population this size, but we could do it. And maybe at the start of the year, there's a certain number of people. There's some emigration, and then at the end of the year, some people have come back. So what we do then is the PT, the denominator, is the average size of the population. Average. To compute the average, you take the population at the start, the population at the end, and you divide by the total number of years you're doing it, right? And the length of the observation period. There we go. Pretty straightforward. More typically, we would just look at the size of the entire population and the length of the observation. So these two things say essentially the same thing, but if we think that the population size is changing from the beginning to the end, then we compute the average. Right, that's incidence. Pretty straightforward stuff. It's just formulas. Let's move on to prevalence. This is a prevalence map of HIV/AIDS if geography were correlated size-wise with prevalence. In other words, Sub-Saharan Africa has the most HIV/AIDS, and so it's the biggest. West Africa has the second biggest, India here, and we have very little. It's kind of cool. Okay. So prevalence rate. Again, the word rate I'm using incorrectly because very often we don't have a time component, but bear with me. The number of affected persons present in a population at a specific time divided by the number of persons in the population at that time. Remember, it's not the population at risk, it's the total population. Important distinction. And this is a measurement of disease burden. We have two different kinds here, point prevalence and period prevalence. Point is at a certain point, and period is over a certain period. So this is the formula. Doesn't matter. Sometimes we express it as a rate per 1,000, but a percent is fine. Again, the old-fashioned sticklers have these rules about, 8 cases per 1,000 people. It's just 10 more than a percent, so why bother? So another way of looking at it is it's people with the disease divided by those with the disease plus those without the disease. In other words, everybody in the population. Same thing. Here's some interesting stats. This is the state obesity rates in 2008 in the USA, which is the fattest state in the U.S. Let's see here. Who's the we're on the wall. Who's the fattest of them all? Is it Wisconsin? That's pretty fat. Anybody fat in Wisconsin? Oregon's fatter than Wisconsin, really? Oregon is outdoorsy. It's got like people hiking. Wisconsin got cheese. Oh, interesting. Okay, point prevalence is a dog pointing. See that? Yeah. So again, number of cases on a specific point in time divided by that risk. That's not right. It's not right. That risk. That's wrong. It's total population on that date. Take out that risk part. That's wrong. Okay? It's a snapshot right now of the prevalence, because prevalence changes on a regular basis. Period prevalence, that's not a period joke, don't kill me, it's there, is the number of cases over that period divided by the number of people in that period. Why is this relevant? Because populations are in flux all the time. Numbers change all the time. So very often they're kind of the same at point and period for certain chronic diseases and large populations, but maybe in the case of outbreaks, they're changing. 23% of this class was left-handed. That is point prevalence. In 2008, 28% of Americans were clinically obese. That's period prevalence. Why? Because this has a time component, a duration, and this is right now, and this period right now. Right? Mind you, you're not going to be not left-handed tomorrow, so this is a bad example. So that's kind of permanent. Right. Do you currently have asthma? That's a point prevalence measurement. Have you had asthma during the last X years? Period prevalence. Have you ever had asthma? That's an cumulative incidence question. So these are the kinds of things we ask on health surveys, and this is the kind of math we then do with those questions. If it helps, and it probably doesn't, you can think about the difference between point and period incidence as an old camera film, where if you click on the camera, that's your point prevalence, because right now I photograph you and all the light on the camera on the back of the second, that's the point. But if I leave the shutter open, that's period collecting. You get the idea, all right? I'm just beating that dead. Why would you beat a dead horse? Why would you beat a horse in general? That's just wrong. So incidence and prevalence here, this also shows us the same kinds of things. So prevalence is the amount of marbles in the thing. Incidence is the rate of new marbles coming in. Here we've got death rate, removing marbles from my population. And we've got if incidence equals death rate, then the prevalence is maintained steadily. Just a way of visualizing what we're talking about, if you care. So there is a relationship between incidence and prevalence. Prevalence is kind of like incidence times the duration of a disease. So if you start from 0, and I'm getting 2 cases per year, every year, after 10 years I've got 20 cases, well, that's my prevalence. I got 20 cases over 10 years, right? That's a prevalence. So they're related. And one of the examples I will show is in Uganda, the incidence of HIV went down from 1990 to 2000 significantly. But that doesn't mean the burden of the disease went down. It just means that the number of new cases every year was coming down. But the existing people with the disease were still there. So the total number of people with the disease was still climbing. It was just climbing more slowly. Another example, right now, the world population is increasing, as we all know, but it's increasing more slowly. The actual incidence rate of people being born is less than it was 20 years ago, believe it or not, but we're still getting more people every year, but the rate is getting more slowly. So you have to keep that straight in your head. Here's an example. Incidence rate of breast cancer in the USA. So this is the age distribution, and here's the incidence rate. Right? So what information does this give you? Any insights that pop out from this? When are you most likely to get breast cancer? What age? Yeah. Sorry, when? 85, you said? You're most likely to get it? Yeah. But yes, absolutely, that's right. But as a population burden, it's less important then because there's so much more fewer women at 85. There are more women here. So we kind of like, at a policy level, we kind of focus over here more because that's when most women are, and that's when they're getting a moderate number of breast cancer cases. Right? That's a hand-waving kind of interpretation. Then look at this. The pitfalls driving our data. We'll look at this when we look at the natural history of disease as well. So if you look at a total population and ask yourself, when do we find out about, as epidemiologists, public health scientists, when do you find out about diseases in order to measure whether or not people have them? Well, there are people out there, people here right now who are sick of something and you don't know it yet. So you don't know you're sick until you feel sick. And maybe when you feel sick, you will go to a doctor. And maybe when you go to your doctor, you'll be tested and they'll diagnose something and maybe be hospitalized. And hopefully you won't die at any point. You can die at any part of these phases if your sickness is bad enough. So for most of the diseases that we know about, we don't actually have data about it until people interact with the system here. Okay, by that point, it's already gone to a certain severity. We're not sampling, unless we do random surveys, we're not sampling this population. We just get a lot of data over here. And even then, unless a test is done, usually in a hospital, we don't find out either. So the data we have is really quite biased. It's an undersampling profoundly of the population, unless you're dying. So the death rates, on the other hand, are sampled throughout the process, and that's where we get a lot of our mortality data from death certificates. So that tends to be fairly robust data. So here's a better way of looking at it. Here is that's what we're looking for. Well, it's the progress of disease through individuals. So you're healthy, the disease starts, maybe you have no symptoms, maybe you don't know you have a disease, but now you get symptoms. Maybe you do something about it, maybe you don't. If you do something about it, maybe you go to the doctor, maybe you ask a friend. If you go to the doctor, maybe it's diagnosed, maybe it isn't. If it's diagnosed, maybe it's treated, maybe it's not. If it's treated, maybe there's a cure, maybe there's all these outcomes here. So at any point, at this point onwards, we tend to have data, but often not here. So where does that data come from? Well, ideally from hospital records, that's pretty good data. Sometimes from doctor records, that's okay data. Sometimes we get interviews, which is pretty bad data. That you probably noticed from some of your other classes, that's not uncommon. And maybe we're doing random surveys of the population. So that's why Health Canada and the U.S. government, wealthy governments in general, spend a lot of time doing these national surveys to sample this population to get this data. Right? It's something called the district-level household survey that most countries try to do. And not every country can afford to do them regularly. We do ours every, I think, 4 or 5 years. You can look up DLS, what's it called again, the District Level House Survey. You can Google that term and the data from various countries will pop up. Okay, so that's your homework for this. I'm going to switch slide decks, so go anywhere. I got some homework for you, so go there. And moving on to mortality. Mortality is death. Dun, 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 dun. So mortality rate is the number of deaths in the population per unit of time. Okay, and we usually give it expressed as units of death per 1,000 individuals per year, but a percent is fine as well. Here are some fun stats and some fun definitions. The crude death rate is a total number of deaths per year per 1,000 people, regardless of why they died or how they died and who they are, just the deaths in the population. So right now, globally, we're looking at 8 deaths per 1,000 people in the world per year. That's actually down significantly. It's been coming down regularly for the last 100 years, so we're seeing progress around the world. Perinatal mortality is what happens around the time of birth, so some weeks before birth and some week after birth. So some of neonatal deaths and fetal deaths per 1,000 births. Right. Maternal mortality rate, that's the number of deaths for pregnant women. Infant mortality, infants are kids less than 1. Children are less than 5 years old. And we're going to do these two things in a couple weeks. Standardized mortalities. Don't worry about this right now. This is going to take up an entire evening of your life. So just file that away for later. So here are the deaths per 1,000 live births in the USA since 1940. And look at that come down dramatically. That's the result of public health. Oh, yes? It's a good question. I think it does. I've often wondered about that. I've gotten no clarification from the officials, but I think it does include. And because I'm not sure, clearly I'm not going to test you on it, right? Yeah. I have to investigate that more thoroughly, but I think it does include it. It shouldn't, though. It's ridiculous that it should. All right. So here we have showing the changes in young people mortality in the USA. It's come down dramatically. See, most of these changes are due to what? Any ideas? No ideas? Health science students. Ha! What have we been teaching the last 4 years? Public health. This is all public health stuff. Clean water, hygiene, vaccination, food, all that fun stuff. Right? That's what brought this down. Okay, maternal mortality rates in Canada have come down since 1925 dramatically. This is what we see right now in some of the worse off developing countries. Like Chad and Yemen, places like that. It's pretty high. In Canada, wasn't that long ago? We had the same rates. So clearly, we got something happened here. Vaccination is a big part of it. Socialized medicine, prenatal care, all that stuff brought our numbers down dramatically. Here we have maternal mortality rates in various countries. Again, I'm not testing you on these things. It's an epi class. It's like how to do the stuff that matters. But this is an interesting context. Right. Mexico is a developed country, so it's pretty high, and Canada is down here. Out of curiosity, you can look at how it works around the world. So, well, I'll skip that. Same with Canada. The mortality rate for children under 5, it's gone down dramatically since the 60s, not that long ago, the 60s. Living memory. Living by me, I was alive in the 60s. Damn you kids. Right? So it's come down dramatically. So we're making a dramatic change right here in Canada. Here we have the causes of death in the USA in 2002. If you're curious about what kills people today, unsurprisingly, heart attack is the biggest killer in the USA and in Canada. Number 2, that's cancer, neoplasms, right? Strokes. These are all sort of chronic behavior and genetic-based diseases, not infectious at all. Those are the biggest killers. Leading causes by sex. Interesting. So men versus women. So how is it ranked here? So for both of us, it looks like cancer is the biggest cause, disease of the heart, blah, 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 blah. Whatever. I'll skip through all that stuff. The interesting part is in injury. Men are far more likely to die of unintentional injury than women. And if you don't know why, just go to YouTube. You'll see why. All right. So where do these data come from? This thing called surveillance. In the international health class, I mentioned surveillance briefly, but surveillance is a big part of population epidemiology. This isn't Big Brother watching you. This is government, or sometimes a health infrastructure, setting up systems to keep track of diseases. It's critical to understand where outbreaks are happening and how many of certain diseases we have. And there are essentially 3 kinds of ways of doing so. There's formal surveillance, which are, again, systems in place for looking for a disease. We have regular surveys or studies. I mentioned the district-level household surveys that many countries do. We've got the NHIS, the National Health Information Survey. USA has the NHANES, the National Health and Nutritional Exam Survey, and that one's intense. That one, a truck actually goes around the country and grabs you. No, they actually invite you in. They sign away, grab you, and they ask you questions about your health, and they take your blood and your urine samples and tissue samples and test for everything. So that way we have this massive database of hundreds of thousands of Americans that we can then extrapolate to understand their health. And this is free. You can access it yourself on the CDC websites. One of my first post-PhD jobs working for the U.S. government was crunching that data at a massive level. We had, in the building, several floors of computer scientists whose job was to crunch that data. And the epidemiologists just told them what to crunch, right? So, hugely important data. And registries. So registries are things like the cancer registry, the diabetes registries. These tend to be not very good data sources. They tend to be run by, independent organizations that reach out to hospitals and patient groups, but, it's there. So surveillance epidemiology. Oh, look at these pictures. It's not that. All right. This is the continuous and systematic process of collection, analysis, interpretation, dissemination, blah, 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 blah. Skip all that stuff. Try to get to the good stuff. It's Friday night, so I'm skipping through a lot of stuff. No one wants to be here, I understand. I'm not testing you on this. This is, for your edification and the growth of yourselves as individuals. So here's an example of a surveillance report produced by the Canadian system. This is crude data from the Canadian injury surveillance system that we get on a weekly basis. So here's unintentional injuries, this number of men, this number of women, combined age distribution. So this is the kind of stuff that's collected, and it comes from police reports, hospital reports, whatever it might be, and just concatenated at a central location. This is an important one, though. This is the Notifiable Disease Surveillance System. So most major countries have this system, and this is our most, I would say, a critical source of data for really important infectious diseases. So by law, if you're a healthcare provider or someone working in health research and you come across a disease in the mandatory notifiable disease list, you must report it to the government under penalty of law. Right? What kinds of things on that list? Well, Ebola, HIV, measles, things that could cause epidemics. So it's imperative that the government understands or knows where they are and that they've been treated. And last week we did the example of computing the risk of getting chlamydia if you're a woman having unprotected sex with a random Canadian man. And I said that data is pretty solid because we have the Notifiable Disease Registry. You can't be tested for chlamydia in Canada and we not know about it. It's possible not to be tested and we don't know about it, but if you've been through the healthcare system, it must be reported. So this is actually what it looks like, what the report looks like when it's sent from a public health unit to the government. And this is a concatenated report. So Quebec, we've got one case of influenza, 45 cases of Hep B in a given month. This is June 2007. So it's collected by public health units that report up to the province, who are also reported up to their federal government. And that linkage is actually kind of slow and inefficient. Those are political barriers. You don't need to know about that. Okay. So if I tell you the prevalence of shigellosis this year is 22 cases per 100,000 people, and the question you've got to ask, is that a big number or a small number? I don't know, right? But what do you need to know to make that determination? You need to know what came before. You need to know what other diseases have that prevalence in the population. You need some context. So surveillance gives us context, and this shows us some context here. Right? So it's been going up and down over years, and this is the result of these systems. Now we know that if it is that high, if it's 22, that's significantly higher than we're used to. So something's going up with this disease. If we didn't have this data, we wouldn't know that this was an epidemic or an outbreak. Okay? So governments have literally scores and sometimes hundreds of surveillance systems. Companies have them too. The university has one for you, like your health records. That's a surveillance system. And as epidemiologists, we can try to get access to those things to do some research on. Internationally, the WHO and other organizations have surveillance systems for big diseases. So this is what the Americans follow. Are you ready? These are all complete surveillance systems run by offices and people. Here's a HIV use. Another one. Look at that list. It goes on forever. And that's a sample. The Canadian ones, well, I gave you one screenshot for the Canadian ones, but we have more. So we have an injury surveillance. So if you are injury prone, you're on that list a lot. We've got our TB surveillance is pretty good. It's one of the better ones in the world. Creutzfeldt-Jakob disease surveillance. What's Creutzfeldt-Jakob disease? Anybody know? Mad cow. It's human mad cow. Mad human. I don't know what it's called. Human mad cow. Right? But we have a disease surveillance for the one case that pops up every year. Right, and so forth. Pretty cool stuff. So there are two kinds of surveillance that I want you to be aware of. Passive and active. I'll say it again. Passive and active. See, it's passive guy, active guy. Okay? Passive and active. Disease comes and the information comes to you. It's kind of hard to distinguish them and when you're kind of stressed out writing an exam. I think of it this way. Think of it from the government's perspective. If you're the government, are you going out and getting the data, i.e., are you commissioning surveys? Are you sending out
student volunteers to the mall to take random blood pressure samples? Or is there a phone line that people call you and say, hey, I saw an HIV case? That's the difference here. So an example, well, here you go. Passive is, okay. Same thing, I just said that. An example of an active surveillance system is the breast cancer screening program. So we actually go out and we do mammograms and we do breast screening activities in malls and schools and stuff. It sounds really creepy. But the Notifiable Disease Registry is a passive type because we sit back and the doctors by law have to call us and tell us they saw a certain case. Okay. More just I'll say exactly the same thing, so I'll skip through all that stuff. Right? Yeah, okay, that's enough of that stuff. I can talk forever about surveillance, but let's go on. I see the look on your faces. Next slide deck here. All right. So the takeaway from the surveillance portion was active versus passive, but you get the point, right? Did you want to see the rest of the slides? I'm assuming not. Okay, so let's move on. A little more. By the way, these images here, these like 20-year images of a fake magazine called Epi Today. That was all the rage 20 years ago. We had these fake covers, which are hilarious if you're an epidemiologist. And maybe at the end of the year, you'll look back at these and laugh your asses off. But right now, they mean nothing to you. But I'm planting the seeds of appreciation that maybe will percolate later on. Oh, that was hilarious. So there it is. That's not a real thing. Epi Today is not a real thing. Okay. Again, mortality death rates. We covered this already. It's the number of deaths in general, divided by people at risk for death. The kinds of things we will look at right now are mortality. Measurements of mortality include some of the things we talked about in the international health class, for those of you who are there. Case fatality rates, YPLLs, which are years of potential life lost, survival, simple survival. We'll do complicated survival later. The daily, which is really important. The DALE, which is less important, and some other cool stuff. Right, this is crude death rate over the years at the global level. There's a man lying in crude oil. See, crude oil. Thank you. Here all we tip your waitress. So, as I mentioned, now we're about 8.5, 8.3 around there. It's come down in 50 years from almost 20. Amazing progress, and we think it'll go down dramatically. Right? Then it's going to go up again for reasons I don't fully understand. Possibly due to the aging population. We'll see, but these are projections. Okay, look at this. This is from your textbook, I believe. No, it's not. It's from a different textbook. This is numbers of cancer-related deaths in the USA from 1900 to now. It's gone up. Should you be alarmed by that statistic? Yes?
It'd be important to know how much the population overall increases.
Very good. Did I write that down already? No, I didn't. Very good. In previous years, it's taken people minutes to figure that out. You got it right away. So clearly, someone watched the video last night. No, very good. That's all right. So that alone is numerator data. It looks alarming, but maybe the base population is also increasing, in which case there has been no change in the death rate. I don't know. Right? In fact, I would suspect that the population growth has been pretty much aligned with this. So, yeah. So it's important to always know what is the denominator. That's one of the first questions we ask ourselves. The trend in number of deaths is upwards. The trend in the risk of death, we don't know. Probably not upwards. Well, maybe slightly upwards. So mortality rates are total number of deaths from all causes divided by total number of persons in that population. It says here at mid-year because we are accounting here for changes in large populations. So if we're looking at, again, Ottawa, we could do the average, right? Those at the start, at the end, and divide by 2, which is kind of the same as doing it mid-year. But in general, it's number of people in the population. We can do it for specific groups of people, like men, women, boys less than 10, whatever it might be. We look at specific rates sometimes. Specific rates look at specific population groups. age-specific, disease-specific, and cost-specific. We're going to spend a lot of time on age-specific death rates when we do standardization, as you will see next week, I believe. Okay? So here's some examples of the kinds of specific death rates. Children-specific, lung cancer, blah, 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 blah. Right, the first important one, the CFR, the case fatality rate. A fun one for the media to report a lot because it's scary. It is the risk of death from something if you already got it. In other words, if you are a case, you've got the disease, how fatal is it for you? So number of deaths by that disease divided by number of people with the disease. Pretty straightforward, right? So Ebola was thought to be one of the deadliest viruses in the world, and it had a CFR of 90%. It means if you got it, you were 90% likely to die of it, right? A couple years ago. But 2014, we had that big outbreak, and the CFR went down to 60%. As I asked in the last class, why? Why would a CFR go down? Yeah?
Treatments available?
Exactly. So it's really sensitive to the knowledge we have of the disease. So with the new outbreak, we have new technologies applied, new attempts to control it. So in general, CFRs for diseases always go down. Well, not always. If you make a concerted effort, they'll always go down. Right? So it looks like this. Number of individuals dying in a certain period of time over those with the disease. So this compares the two. A mortality rate, the denominator is the entire population at risk of dying. Who's at risk of dying? Well, the living. Right? And it looks at the risk of dying from the disease in general. Case fatality report, the denominator is limited to those who already have the disease. It's a measurement of severity. And it's a good measurement for the benefits of a new therapy. So before our new Ebola treatments, the CFR was 90. After the new Ebola treatments, the CFR is 60. So that shows us that the new treatments have a profound effect on the severity of the disease. Okay, so we've got an example. The population of 100,000 people, of which 20 are sick with disease X, and 1 year, 18 of the 20 die from the disease. Okay, what is the mortality rate for disease X? Well, the denominator is everyone who is at risk of getting it. That's 100,000. And the numerator is going to be those who died. So 18 died. Okay. So the CFR would be the same thing, except the denominator is going to be those who got the disease. So 20. Here 20, 9%. Straightforward stuff, pretty easy. Another example. In a population of 4.5 million, in a given year, 45,000 deaths from all causes occurred. 30,000 of those were age-related among 650,000 who got HIV. So this is a typical question, right? There's a lot of numbers here. It's a bit confusing. You have to tease out the information because everything comes down to dividing two numbers. Mortality rate from all causes. Okay. 4.5 million people at risk of dying, all causes 45,000. So divide that into that, and we get 1%. Cause mortality rate for AIDS. Okay, so cause-specific meaning those who died of AIDS. So 30,000 died of AIDS from that 4.5 million, 0.7%. And CFR is going to be those who got the disease, which is HIV. Our numerator is going to be 30,000. So divide those two, 4.6%. Straightforward stuff. And each of them tells us something different about the disease and the effect on the population. Oh, look, go miss slides. Go miss slides or fill the blanks, right? That was fun. Okay, let's do this together. Mortality is an index of the severity of the disease. Cool. Mortality can also be an index of the blank. Well, incidence, I'm assuming. Okay. Mortality, I'm going to be the same. It's going to be incidence, right? Incidence when CFR is high. Why is that? Okay, let's look at that carefully. If the CFR is high, it means, like close to 100%, that means if you get it, you die from it. In other words, getting it is the same as dying from it. What's incidence? Incidence is getting it. What's CFR? Dying from it. So if the CFR is high, getting it and dying from it are the same. Incidence and mortality are the same. It's all the same. Okay, next measurement is the PMR, the proportional mortality rate or ratio. And again, I'm using that rate incorrectly, if there's no time measurement. It is very much a ratio, though. Remember, ratios, units fall in. So the PMR is the number of deaths from a specific cause in a specific period of time per 100 deaths from all the causes in the same time period. What does that mean? The fraction of all, so if everyone who dies, the fraction of those deaths that can be attributed to the disease that we care about. So we use this when we have a lot of information about deaths and not a whole lot of anything else. So we're looking at causes for certain kinds of deaths. So here's an example. The PMR for cardiovascular disease in the USA is number of deaths divided by total number of deaths in the USA. So our same examples before. Mortality rate from our causes, same as before, 45,000 divided by 4.5 million. Right? Cause-specific mortality, same as before, 30,000 divided by 4.5 million. CFR, same as before, 30,000 divided by 600,000. Okay. PMR, though, of all the people who died, 45,000, how many died of AIDS? 30,000. Right? So in other words, we know that even though the AIDS here is not that severe, 4.6, well, depending on perspective, we know that people in general aren't dying at a tremendous rate, right? It's lower than the global rate. AIDS, though, is the biggest killer of things that will kill you in this particular country. So let's compare two communities. We have ReWalkville and Gomezland. Yeah. ReWalkville's got 1,000 damn sexy residents, damn straight. Gomezland has 1,000 dignified. So we've got 30 people died of all causes in ReWalkville, while the same year 15 died of Gomezland. They're dying of sexiness. Okay, the same year 3 of the deaths were due to heart disease. Okay, fine. Their hearts couldn't take the sexiness. So you're going to compute these things for these populations. So, and these are the numbers. I won't go through it. You can do them yourself and see how it works, right? So, the important part here is we can now interpret these numbers. Interpret percents, this is a little easy to look at. So here we've got ReWalkville has a higher death rate overall, but the PMR, heart disease, appears to be a bigger contributor of death in Gomezland, but the mortality rate for heart disease is the same in both. So it's kind of hard to gain sort of public health knowledge from all this. What's the risk of dying of heart disease in each community? Well, 23%, right? The same. Which community has a greater risk of dying of heart disease? Well, they're kind of the same, even though the numbers are different. They're kind of the same. Okay. There's something called early and late mortality, which can be confusing, but it's just the same as comparing two populations. It's just that it's the same population looked at early and looked at late. Okay? So let's say there's an intervention to try to prevent death caused by a disease, and we try to distinguish between early and late. So early is the total number of deaths in the early stages, and late is going to be the number of deaths in the late stages. Why do we care about this? Because we care if treatment is having a change later on. If there's actually less mortality in the later phase, well, it means that the long-term treatment is having a cumulative positive effect, that kind of thing. So here's some examples from literature. Right, if you're going to read these, you can. Looking at early versus late, another one, early versus late. So here we have an example. 1,000 people. We're going to compute the cause-specific mortality rates and the PMRs for each period. So here we've got early and late period, and looking at heart disease, cancer, and all causes. Okay, so in the early period, heart disease is 40 of the 1,000 reasons for dying. In the late, it's 80. In the early phase, 20 is the cancer, and late hasn't changed. So these two hasn't changed. Heart disease has changed a lot. So people are dying more, apparently, of heart disease later on. So the PMR for heart disease in the early phase is going to be 40 divided by all of them, 50%. Let's fill it all in there. You can see right now what's going on. So here we've got another look at this. So as this population goes through their treatment, they're dying less of cancer and less of everything else, but they're dying more of heart disease. So if this was a treatment program for treating heart disease, well, they're not doing that well. If it was a treatment program for cancer, well, maybe they are. Maybe they are doing well. Okay, here's an interesting question. Here we have a population looking at dumbass disease and nose pickery. Right, so the disease, 6% died of dumbass disease. I'm telling you, stupid is fatal. And 1% died of nose pickery. They dug this too deep. And so we've got, of everyone who died, 26% died of deep digging, and 14% died of being a dumbass. And the CFR is that. So which disease is more serious? Right there, we can compute all this stuff. At the end of the day, the policymaker wants to know which one do we care most about. It depends. It just depends. Depends what is it you're trying to figure out. If you got the thing, which one should scare you the most? Well, clearly dumbass disease. Right? Which one is killing most of our population? Well, dumbass disease. On the other hand, of all the things that are killing us, which one has the biggest share? Well, no stickery. So it's a difficult question. There's no obvious answer. Okay, so let's look at burden of disease now. How would you measure a population's burden of disease? And by the way, the first year I came to this university, I wasn't a professor, I was a judge at the poster contest that happens at the end of this course every year. And as I mentioned, this year it's going to be electronic, and previous years it was a physical poster presentation. And they bring in external judges, and I was an external judge. I remember the first people I spoke to. I remember the title of their poster was "The Burden of Schizophrenia Amongst Middle-Aged Women in Alberta," I think it was. So the first question I asked them was, so, define burden. Broke into tears. Yeah. Since then, I've been trying to make people cry ever since. So I've succeeded a couple times. So the lesson there is, if you're going to use words on your poster, be able to define those words. Okay, let's start with the years of potential life loss, the YPLL. This is a measurement of premature death. Clearly, if you die young, you have lost more years than if you die later. Okay? So, in other words, death at a younger age we assume involves a loss of more potential than death at a later year. Is that one could argue philosophically that because you're younger than me, your life is worth more, you've got more potential. On the other hand, I've done shit, I know shit, so I'm worth more. So it depends on your perspective. I'm going to debate you about that. Okay, so if you're expected to live 65 and the disease kills you at 20, then you have lost 45 years. So the YPLL, years of potential life loss, is 45. Obviously, it depends on how many years you were expected to live, which can be problematic. Okay, so in Canada, in 1993, injuries killed about 10,000 people. Cancer killed about 25,000 people. So you'd assume from that statistic that cancer is the bigger deal. Cancer is more serious. That's reasonable, given that statistic. Okay? But cancer affected more old people, and injuries killed more young people. So cancer caused 300,000 years of potential lives lost in the population. Injuries caused 336,000 years of potential lives lost. So now, which one's more serious? It depends on your perspective. If you're a policymaker, you could argue we care about, all this potential tax income we're not going to get, as opposed to, all these old folks hanging out no longer. So, it depends. So, you need to compute the IPLL, you need a time period, you need a population, young people, old people, breast cancer, whatever it might be. You need a life expectancy, how long they are expected to live, because you're going to be subtracting. So the YPLLs are going to be the sum of all the YPLLs for all the people who were lost to that disease. So look at this. This is the YPLLs in Canada. No, the USA, sorry. I forgot what year this is, but it's recent. So of all causes in the USA, they lost 11 million years of potential life in a given year. Most of that was due to injury. Again, go to YouTube for examples. And after that, cancer. Right? So that's one way of looking at death. Unsurprisingly, for children, injuries are the biggest source of years of potential life lost. In other words, the biggest source of mortality. Genetics is another one, premature birth, and so forth. Obviously, if it kills you earlier, you're going to have more YPLLs. Why do we have it? Well, it helps us do policy. It priorities. It gives us, a sense of what's happening in terms of trending for premature mortality. It's really good for just research and policy in general. So the next thing we'll look at is the quality adjusted life year. And this is very commonly used in clinical study, in government research. So the quality is a measurement of the quality of one's life after something has happened. So maybe your life is fine. So we'll call your life a 1. 1 is fine. But maybe you break your leg for that year. How long it takes, for some reason you keep breaking that leg. It's broken the entire year. So the quality of your life is now reduced somewhat. Maybe it's not a 1, maybe it's a 0.7. Right? Or maybe you had a heart attack and now you can't run and play with your kids. So the quality of your life is down to 0.6. So it's a way to quantify a reduction in the quality of your life. Why do we care about this? Because it allows us to make decisions about whether or not to do certain things. I saw a report just this morning for a government agency. We use qualities to determine whether or not a certain drug should be funded by the government for treating dermatitis, treating a skin condition. Right? So on qualities are on the outcome. So if we use this drug, this will give us this many qualities. If we don't, it'll give us another bunch of qualities. So let's go through the qualities. It stands for the quality adjusted life year. You can read about it here if you want. And it measures the quality and the quantity of life lived as a result of a certain medical thing, intervention, event. So the way you compute it is, there's an index. The index goes from 0 to 1, and you multiply that index by the year that you would have lived. Who determined this index? A committee is struck. It says, well, blindness is worth 0.7 of a year spent not blind. Deafness is worth 0.85 of a year not spent deaf. Obviously, it's politically problematic, right? It's qualitative, but that's what we have. So here's an example. A new heart valve saves your life. You would have died otherwise. On the other hand, it reduces the quality of your life now because now you can't run and play with your dog or something. So yeah, you'll live another 10 years, but those 10 years are worth 6 years of full health. So in other words, it gave you 6 qualities that you wouldn't otherwise have. That's the way it works. Another example. Bob is 50 and has heart disease, and he is not expected to live out this year. He's given a heart stent, and to extend his life, he expects to live 70. So he's gained 20 years of life. Great. However, because of the stent, he's got to give up all exertion, and his life kind of sucks. So they think that the stent represents a quality index of 0.6. How many qualities did the stent give Bob? The stent gave Bob 20 years, but he actually gave him 20 times 0.6, 12 quality adjusted years. So maybe Bob had other options. Maybe he could have had a drug therapy, and the drug therapy would have given him 20 years at 0.7 index, so 14 qualities. Right? So you can compare the advantageousness of various interventions if we use qualities. Okay, that's done there. We have a thing called the DALE. This is the Disability Adjusted Life Expectancy. So this is a measure of life expectancy, but it's been modified to account for the number of years you'll spend disabled. It's kind of similar. Right? We'll figure out that a year spent disabled is worth this much of a year spent not disabled. Again, politically problematic. This is done. So in Japan, they have a very high life expectancy, like 81, probably up to 82 years by now, right, computed at birth. But their DALE, their disability adjusted life expectancy, is about 74.5 years. In other words, those last 6 years or so will be spent somewhat disabled. So it works the same way. There is an index that's created by a committee, and you multiply that index times the number of years you've had, and that gives you the DALE. Yeah. Nothing surprising there. That takes us to life expectancy in general. Life expectancy, again, we covered this in the international health class. I know there's substantial overlap in the two classes. So for you guys, this will be review. Life expectancy is one of those things that people think they understand, but they don't really. When we say we have an aging population, what does that mean? Does that mean everyone is living longer? Does that mean I'm going to live substantially longer than my parents and my grandparents? Does that mean you're going to live longer than me? I doubt it. Look at me, I'm pretty fit. Right? There's a little bit improvement in lifespan, in the last couple of generations. Meaning the last couple of 100 years, there's significant improvement in lifespan. When we say we have an aging population, what we're saying is we have more old people. So the average age is greater. So let's see what that looks like. Life expectancy is the expected time you expect to remain alive, right? And you have to give it relative to a time in your life. It's computed at a certain age. So if someone says life expectancy in this country is blah, ask them, computed when? Usually it's computed at birth. Sometimes you say life expectancy computed at 20, life expectancy at 25, whatever it might be. Okay, and we do it using something called life tables. If you're looking for a career and you don't mind excruciating boredom, you can consider becoming an actuary. Actuaries live on life tables, and they're the ones who compute how much your insurance premiums are based upon the experiences of your cohort. And it's a difficult path becoming an actuary, but it's a fantastic career option. If this intrigues you, consider it. They're well employed and make good money, but it's a lot of this. So, life expectancy at birth is 32 years in Swaziland, 81 in Japan. So that's pretty extreme. What you think about where that that difference manifests, at what point in the lifespan. So, I showed this graph in almost every class I can because it's an important graph. This is the changes in life expectancy in the USA from 1850 to about today. Look at this. So life expectancy computed at birth in 1850 was 40. So a newborn is expected to live to 40. Life expectancy computed at birth today is about 75 or so, right? So a newborn is expected to live 75. Huge improvement. But life expectancy computed at 70 in 1850 was 80. Today, it's like 82. Not a whole lot of change. So all of the advantages, all the improvements in life expectancy have been amongst the extremely young, the babies, infants, and children. Because of those public health interventions we talked about earlier. Vaccination, the prenatal care, nutrition, all that fun stuff. Right? That's also why life expectancy is shooting up in low-income countries, because now they're getting the same advantages of prenatal care and nutrition and vaccines. Got a hand? Or are you stretching? Okay. Doing a death dance. Right. So now you see Swaziland, 32 years, Japan, 81 years. The difference in Swaziland, their children still die very young. Right? So in other words, the longer you live, the longer you're probably going to live. Every time you get past a certain year's worth of hurdles, you're in the more enriched cohort. So when you're born, a bunch of your kids in the nursery died because they had their congenital issues, they were born weak or they're premature, whatever it might be. Okay? So when they died, the average health of the remaining group was higher. So suddenly, the average life expectancy was higher. The next year, a bunch of other really weak kids died. And the ones who lived were, on average, healthier because the weaker ones had died away. And so your life expectancy. So in other words, the older you get, you're in a more enriched population that's going to live longer. You're going to live longer the older you get, until you get to 16. And suddenly, life expectancy comes down again. Why is that? Everyone knows. Someone tell me. What happened with 16 in North America? They start driving, right? So life expectancy drops to 16, goes up again at 17 because all the bad drivers have died. So the population of good drivers is now enriched. Right? It keeps on going higher and higher and higher. And different demographics have different experiences. So in the USA, black men have a hard time. They're more likely to die of violence and a variety of issues well up until their 50s. Until they get in the 50s and 60s, and then they live forever. So in the USA, old age homes are overly represented by old white women and old black men, which is hilarious. Okay. Now the problem is you can't use life expectancy as a gauge of population health because it's not a measurement of health, it's a measurement of age, and age and health don't go together. So the older you are, the more disabled you are, the less productive you are. So if you're measuring, whether a society is healthy, that may not be the best measure. Right? Some people have proposed using a healthy life expectancy, similar to the DALE. The DALE is a disability-adjusted life expectancy. Healthy life expectancy is the opposite. It's like we only look at how long we expect to be healthy, as opposed to the regular life expectancy, which is the total life expectancy. Whatever. The point is that there are all kinds of different ways of looking at it, but we still use the regular life expectancy. Now the important one, the important index we're going to talk about is the daily. The daily looks like the quality, but it's not. It's got a D instead of a Q. And some people confuse them. And the way you think about the difference, I do anyway, the daily is bad and the quality is good. You want more qualities, you want fewer dailies. Okay? So let's look at what a daily is. It changed everything. So it's only been around for about 20 years. But before the daily was brought in, we didn't have a way to measure the impact of non-fatal or limitedly fatal occurrences. The best way we looked at population health was to look at just things that killed you. The daily allows us to measure things that kill you and things that make you miserable. Combination. So it's a bad thing. It's a number of years of productive life lost in the population due both to death and disability. In other words, what's your daily golfing joke that no one gets? Because no one watches golf, including me. So it's a combination of years of life lost and years of life spent disabled. Okay? How does that look? It's important because we have, again, a measure for things that are burdensome in a population, but not necessarily going to kill you. So here is the current list ranking of dailies in the world. 1999, obviously it's out of date. I got to update this slide at some point. So acute lower infections, right? HIV, depression makes number 5. So now we have a way of measuring the impact of mental health issues, which is very important. This looks at 2004. This is a list of things that will kill you versus things that give us dailies. So the biggest thing that kills us is heart disease. The biggest thing that gives us dailies is infection. The second biggest thing that kills us is stroke. The second biggest thing that gives us dailies is diarrhea. That's miserable, right? And so forth, down the list. Depression makes it number 3. So one of the reasons that mental illness is now part of the global conversation is the daily allows us to measure it. Again, this is an old slide, but now we're projecting just 3 years in the future. We think that in a few years, the number 1 most burdensome disease in the world due to dailies, now not just death, is heart disease, and number 2 would be depression. 3, cars, not surprising. Okay. Diarrhea makes top 10 again. Yikes. All right. That just shows the changes in expected dailies. Right. So, I think the last thing we'll look at today is survival. There are 2 kinds of survival rates. Simple survival and complex survival. And we won't deal with complex survival today. Complex survival is something we're going to call Kaplan-Meier survival curves. And I hate them. I have a trauma every time I try to explain them. So I always set aside an entire lecture so I can prepare my trauma for it. So we'll talk about simple survival today. So look, I go on this slide. Blank is a probability remaining alive for a certain amount of time. Survival? Yes. Okay, well, I know it's my slide. I should know this. I haven't done this in years. Okay, so often we compute survival in certain known time chunks. 1 in 5 year, very common. We can do it for any number of years. For example, 5-year survival rates for this kind of leukemia is 0.14, which says that 14% of the patients are expected to survive at least 5 years. And this is the formula for simple survival. The number of people we start with, survival is number of people we start with minus the number of people who died divided by the number of people we start with. Pretty straightforward. And of course, there's going to be a little bit of changes and caveats here. So, look at this depiction. 1, 2, 3, 4, 5, 6 people that were observed. So, the first person observed for 5 years. This person was observed for 2 years, then censored. What does censored mean? It can mean any number of things. It can mean they're thrown out of the study. It can mean they left the study. It can mean they lost their data. It's just that we don't know what happened to them. So censoring is a critical component of clinical studies. Right? Let me see, this guy died in 1 year. D, this guy lasted the entire thing and didn't die. This person, we lost them at 2 years. And last person, they died at 4 years. Okay, so the reason survival rates are kind of prickly is we disagree on how to deal with these censored people. And they happen all the time. People just leave a study or lose track of them or something. And we can think about them as having died. If we think about them having died, we're going to overestimate the death rate. If we think about them as having not died, we underestimate the death rate. So there's not a whole lot to do with them until we do the Kaplan-Meier method in a couple of weeks. But right now, the simple survival kind of assumes they're alive, because we only care about the ones who died, and we don't make any assumptions about the ones we don't know who didn't die. Okay, here we go. So at 2 years, let's complete the 2-year survival. At 2 years, we started out with 1, 2, 3, 4, 5, 6 people. How many are dead at 2 years? 1. 1 is dead at 2 years. So 5 are left. 5 out of 6 gives us 83%. So at 2 years, the survival rate is 83%. Great. Grade 3 math, no problem there. Okay? So like I said, 1 and 2 and 5 years are standard. We can do anything. So, so prostate cancer has a higher 1-year overall survival rate than pancreatic cancer, and therefore has a better prognosis. That's how we use that. Now you can break it down by age as well. In the textbook, leukemia has a survival rate of 19%, but if you're under 65, it's 31%. If you're over 65, it's 4%. Right? So we can break these things down forever, which brings me back to the only epidemiology joke I know, which I told you already. Listen, epidemiologists, some of this is broken down by age and sex, because that's what we do. We break things down by age and sex a lot. Okay. Now the question is, are the older folks dying of cancer, or are they dying of something else? They could just be dying of old age. Right? Does that matter? It kind of does, because here I told you all we care about is that they died. So simple survival only measures death and doesn't tell us why they died. I could add an addition to this and say cause-specific survival rate, which is what we're going to do. Okay? So survival tells us something about disease severity. It's kind of like the case fatality rate, except over a period of time. How long does it take to kill you? Right? There's a thing called the relative survival rate, which confuses some students. So the relative survival rate is the survival rate of your sample, like those 6 guys you just saw, divided by the survival rate of the general population. Why would we care about that? Because everyone's going to die anyway. Sorry to shock you, sorry to scare you with that, but it's true. Everyone except me is going to die eventually, right? And so your sample population, let's say they're a cancer population, you're looking at their survival rate, how much they're dying. It could be shocking to you that 5% of your population, of your sample is dying, but maybe 5% of everyone's dying, in which case you shouldn't be shocked. So it's important to take into consideration the baseline survival rate. In other words, the expected survival rate. So if I divide them, and they're the same, I should get 1. If I divide something by itself, I should get 1. That's the ratio here. 1 is the magic number of ratios. If I divide them and I get a number greater than 1, then I know that my sample is dying or surviving at a higher rate than the general population. If I get a number less than 1, then I know that my sample is surviving at a lower rate than the general population. Here's an example. Okay, so percentage of cancer patients who are alive at 2 years divided by the percentage of the general population who are alive at 2 years. Okay, here's some quotes from Health Canada that says the same thing I just said. I don't know why I have these slides here, but you can read them. You can use better definitions. Yeah, that's why we have it, RSR. Also, it's a measure of patient survival corrected for the effect of other independent causes of death, whatever that means. That's fine. Okay. So I mentioned that when we looked at survival, we don't know what killed them necessarily. So we can be specific. We can say we care about the cause-specific survival rate as well. So this gives us the chances of death due to a particular condition. Right? So the 5-year cause-specific survival for Hodgkin's lymphoma is 85% when treated by a certain thing. This means that 15% are, like 15% who died directly of this lymphoma. They didn't die of something else. They weren't killed by a car or didn't die of old age or something. So let's work through another example. Same data as before, same 6 people, but I've added some nuances here. First guy lasts through the entire study, doesn't die. Second guy, again, disappears at 2 years. Third guy dies in 1 year. Well, he's hit by a truck. We know that. We saw it. It's outside the lab. Right? Fourth guy lasts the entire thing. This guy disappears, we don't know why. And this guy dies actually of the cancer that we care about at 4 years. So the 5-year survival rate computed the regular way would be, we started with 6, right? We lost 1, 2, so down to 4. 4 divided by 6 is 67%. That's the simple survival rate. The cause-specific survival rate would be, how many died of the cancer? Just 1. So that's 5 out of 6, 83%. Right? Which is odd, if you think about it. Here we're saying the cause-specific survival rate of cancer is better than the overall survival rate. It's a misleading statistic. It's just that we're saying that the cancer is not what's going to kill you in this population. It's going to be the truck or other things. Okay? Don't worry about the interpretation that much. If you struggle with the numbers, just do the math yourself again and again until it becomes clear to you. Right. The problem with this mortality data, unless you're watching the study population itself, is that we get these data mostly from death certificates. Oh, question? Yes?
Question about the two slides for the...
This one? This one here? No? This one?
The one with the orange. You got it.
This one? What? Orange text. What orange text?
Point around.
Right, there you go.
This one here?
Yeah.
Oh, okay.
What's the denominator?
Yeah.
Are we supposed to already know the survival rate of people who have NCD to be relatively supposed to have that information?
In this example, the denominator are people with the disease, right? So there's a clinical example here. So amongst people with Hodgkin's lymphoma, 85% will still be alive in 5 years after giving. Did I lose power here? Shit, 1 second. We're back on. Okay, so this example, the denominator here is, well, the population are people with the disease. So are you asking, do we know about the general population? This is not a relative survival rate computation. So I may ask you, I may give you the survival rate of the general population as well and ask you to divide that, and that would give you the RSR. Answer your question?
So it's different from the slide that's next to it.
It's different from this one. Right, yes. Yes. It's cost specific, but it's not relative survival. Right? Cool. Thanks. Yeah, talk about that. Okay. Cool. Again, mortality data is problematic because we get it from death certificates. This is what a death certificate looks like. There's not a whole lot on there. There's a couple of spots here. Say here the primary thing that killed the person, and maybe a couple of other conditions that are there. Right? Or sometimes it's like this: rupture of myocardium, acute. So here is heart disease killed them. It doesn't tell them about their underlying diabetes or about maybe they had AIDS as well. Maybe it's heart disease caused by some other condition. So the amount of data we have is very, very poor. We have this thing called the ICD. Now you've covered ICD before in the classes, I assume, right? International Classification of Disease. Good. So we get a lot of data from this, and there are databases like the National Ambulatory Database that the hospitals maintain. Every time you go to the hospital, the intake triage nurse makes a file and entry what you come in presenting with. Maybe you have a headache, right? And there's a code for that, the IC9 system, that goes in. What you're diagnosed with, that has a code as well, that goes in. And so we have pretty good data at the national level over what people are presenting with based upon the ICD. I'm not sure if I told you already about the, in grad school, that assignment I had to watch ER for a year. Did I tell that story? I guess so. Yeah, all right, in the story. So in grad school, we had to watch ER for a year, the TV show ER. And then we had to watch as all the patients come into the fake hospital on the TV show and figure out what their ICD code was. It was interesting. And then compare it at the end of the year to the actual ambulatory statistics from that particular hospital in Chicago or Boston? I think Chicago. Right? What we found, of course, was that a lot more gunshot wounds on the TV show, a lot more women on the TV show, people for George Clooney to have affairs with, a lot fewer black people because they're racist. And I discovered there's an episode where someone comes in claiming to be a werewolf. And I'm the only person in the class who got this right, because everyone else coded as schizophrenia. No. There's actually an ICD code for werewolfism, for lycanthropy. It's a kind of schizophrenia. Look it up. I'm very proud that I found that. All right. Okay, so death certificates have ICD codes on them. And ICD isn't the only system that's out there, but it's the most popular one. It is problematic because the codes have changed over time. And if you're looking just at the death certificates and the codes, unaware of the historical changes, you'll have a skewed impression of the way that diseases have progressed. For example, look at this. These are the deaths by diabetes from 1930 to 1960 in the USA. In 1950, all of a sudden, people stopped dying of diabetes. What magical thing happened there? What happened there was the death certificate codes changed. They just stopped coding this thing as diabetes, now it's some other complication. Right? If we didn't know that, you'd assume that some magical intervention was introduced in the USA in 1950. In 1993, a new definition of AIDS was introduced. So look at this. So suddenly, these are people dying of AIDS in the USA. Here we have this massive jump. People weren't dying more or getting it more. It was just that the definitions changed, and they allowed that into the death certificates. So here are some actual causes of death that were written down on death certificates in the early 1900s. Died suddenly without the aid of a physician. A mother died in infancy. That's so strange. It's unusual. Deceased had never been fatally sick before. No. Died suddenly, nothing serious. Went to bed feeling well, woke up dead. Okay, and that's your homework for that one. That's it. You're all free to go now. All right.